Hey, welcome to This Week in Pharmacy. I am the host of This Week in Pharmacy, TWIRx, as I like to say. All the cool kids say TWIRx. That's hashtag TWIRx. And if you're twerksing, you're worksing in pharmacy. That sounds really stupid, doesn't it? I will admit it. All right. Listen, we have a lot to talk about today. There are some things that are crucial that are happening as you are listening to this. Actually, this was recorded just earlier today, published today. There are pharmacist champions for community pharmacy, specifically independent community pharmacy, who are in front of Express Scripts capital, or not their capital, their headquarters, and Doug Hoy with the NCPA, the National Community Pharmacists Association, is there, as well as people from Pharmacists United for Truth and Transparency, who is a Pharmacy Podcast Network member. We're very proud of their work. I am blown away by their work, so I'm going to be playing some of their news clips. But something that I think I'd like to bring attention to that's making international news is a very special piece I'm going to share with you right now. And I'm telling you the differences that pharmacists are making on pharmacy care internationally, in our country, in your hometown. It's just enormous. I want you to hear from pharmacy owner of CareMed Pharmacy in New Jersey, Dr. Ghana. She is amazing. Gada Abukowik is in Gaza right now, and this made national news. The headline is American Doctors Trapped in Gaza Begin Evacuation, including a New Jersey pharmacist and surgeon. So let me play this clip for you now.
My name is Gada Abukowik. I am a pharmacist and I'm the CEO of multiple pharmacies in New Jersey. I am the president of the nonprofit organization Amalna in New Jersey. So just imagine that injured people coming in the ambulance, and the doctors are there and the surgeons are there, but there is no staff to do the surgery. And also, if the staff are there, you don't have resources, you don't have medical equipment. Many medications are out of stock. Even though we brought with us so many things, it went fast. And it's a heartbreaking story. One time I was walking in the night and there was 8-year-old kid, and he's holding the Lantus and Novolog in his hand. And he was a kind of sad. And when I went to him, I told him, what's going on? He said, my parents died and my siblings died. I only have one 5-year-old I'm taking care of, and I don't have insulin to give him his shot in the night. And the outpatient pharmacy told me that there is no insulin. And he was right. There was no insulin in the outpatient pharmacy. So just imagine you are not able to help this kid who is taking care of sibling, the only sibling, and he's coming to get an insulin for him. So it is the same thing. People here, they need the help. They are injured and they are dying. So we are not talking about politics, but the urge, the message, there has to be international healthcare providers helping people here all the time, and to have a safe place, a green zone for these people to be helped. By the way, kids, we see kids' cases more than adults. The kids that are killed every day, that we see them every day, more than nowadays, around 10 to 15 kids are killed more than adults. So they need some kind of help. So this is our message as a human being helping each other. There has to be a safe zone, green zone for healthcare providers to take care of each other.
That is powerful. So proud of Gada and her work, and the work of all of those healthcare professionals. I want to echo what Gada said, and she believes this. I know her. I've met her several times at national pharmacy conferences. She's one of our champions and now, of course, an international servant right now in Gaza, helping children, helping people. We're talking about human beings. This has nothing to do with the history, the politics, the complexity of any of the feuding between Israel and Palestine and what's happening in Gaza. This is about children, and it's about people. And pharmacists are stepping up. Gada is stepping up. She saw something happening. She went there. She's risking her life. She's there now taking care of people. And I agree with her that we have to come together as a healthcare Red Cross mentality level community, international community, and come together just to help people, just to get people back to life in their health, especially our children. So very proud of Gada's work. Very proud of our pharmacists stepping up and leading the changes that must take place and helping people right now who are, as Gada said, dying, and she's there. All right, let's turn to another subject. I want to talk about Express Scripts. I don't know if you know that this is happening, but today on the 17th of May, we had a group of people, pharmacy professionals, that were present in front of Express Scripts headquarters, and I want to play this clip for you from Doug Hoy. He is the CEO of the NCPA.
An announcement about how they want to work with independent pharmacies. They even started an independent pharmacy advisory council. I've always heard that actions speak louder than words. Since they made that announcement, another 500 independent pharmacies have died because of PBMs. ESI's blatant disregard for independent pharmacies and patients has only gotten worse. Just another ESI lie. I'm here for the blind, elderly widow of a military veteran. The independent pharmacy she went to for years personally delivered her prescriptions to her and put her medications in special packaging, remember she's blind, so that she was confident in taking her medications, the right medications at the right time. She's now terrified because her pharmacy was forced to make the awful choice of either accepting ESI's TRICARE contract, which pays pharmacies less than what it costs them to buy the drug, or to stay in business. The pharmacy had to make the choice to stay in business. I'm here because companies I'm about to name have hired Express Scripts, and people need to know that these companies, knowingly or not, are killing off small businesses, even some of their own customers and alumnus. Disney.
Shame.
Morgan Stanley.
Shame.
Farmers Insurance.
Shame.
Johnson & Johnson.
Shame.
Texas A&M.
Shame.
Ohio State University.
Shame.
The South Carolina State Health Plan.
Shame.
The New York City Employee Plan.
Shame.
That's just a sample. These companies are killing small businesses, again, knowingly or not. They need to be held accountable for why they do not fire their PBM, hire a transparent PBM, help small businesses, help patients, help consumers, and help their employees.
Very powerful. Applause to the NCPA applauding the Pharmacists United for Truth and Transparency team, as well as Shane Jereminsky and the Pizza's Not Working crew. I think Dr. Maurice Shaw made an appearance at that. He's known as the Doctor of Comedy. And of course, they're putting together the Pharmacist Union and the union to really bring together the pharmacy profession. And that's really what we want. None of us want to see pharmacy fail, but the way that it's being managed and stopping from patients from accessing pharmacy care, it can't go on like that any longer. And I'm sure that you're seeing a massive revolting, and this is part of it, is being able to stand up for your profession. All right, we have a special follow-up interview to this exact subject, and we want to jump into the topic. And I just want to give you a heads up. Independent pharmacists cry foul at Kemp veto, and that's Governor Kemp in the state of Georgia. This is a really interesting conversation. You're not going to want to miss this because this affects the rest of our nation. So I want you to have a heads up on This Week in Pharmacy. Hey, and on This Week in Pharmacy, I'm not sure if you heard about this, but it's in my opinion. I wrote this on LinkedIn. So if you follow me on LinkedIn, please do if you're in the pharmacy profession. I think working together and referencing each other's materials and expertise is the reason why pharmacy is on a much faster track of transforming. And so part of what I wrote on LinkedIn was independent pharmacy owners in Georgia, they take another blow to the face as the profession of pharmacy has been, shaken, and public health services to their communities are threatened by the latest decisions on Senate Bill 198. And owners of independent pharmacies in Georgia are criticizing governor's office, Governor Brian Kemp, in his decision this week to veto legislation aimed at rectifying a situation that has left a competitive disadvantage with pharmacy chains. So I have some special guests, and we're going to dive into this subject. This subject today, if you're interested in being part of this discussion, please link up with us at Pharmacy Podcast on all social media platforms. Every single one of them at Pharmacy Podcast. Get involved in the conversation. We watch as we actually do these TWIRx, so we'll interact with you. All right, we're going to jump into this. We're going to be talking about pharmacy deserts, the impact on public health, technology that could be employed to actually kind of, strengthen that. We're going to be talking about timelines of what's about to happen to the United States healthcare system. And we're also going to be talking about what people in the trenches are doing to help their communities. So I want to welcome Greg and Nikki to the conversations, and I want you both to introduce yourself to our listeners, thousands of pharmacists out there across the globe, actually, and introduce yourself. Tell us a little bit about yourself, what pharmacy school that you went to, or what school that you went to, and just tell us about your background. I'm going to start out with Greg.
Hey, Todd. Thank you so much for having me. Really excited to be here, and really appreciate you shining a light on what Georgia independent pharmacists are going through in the state. I'm looking forward to talking to you about it. So full name, Greg Reibold. I am APCI, American Pharmacy Cooperatives, Vice President of Healthcare Policy and General Counsel, and I'm a healthcare attorney. I've been there for probably getting close to 3 years, maybe 2.5 years. And before that, I was a VP of Government Affairs and General Counsel for the Georgia Pharmacy Association. And a lot of my time is spent on advocating for independent pharmacies, advocating for transparency and fairness in prescription drug pricing, and advocating, really about the value that independent pharmacists bring to the healthcare system as a whole. And so that's, again, where I spend the bulk of my time.
Greg and I have known of each other for years now. It's got to be more than 5 years. And
Yes.
There have been conferences where Greg and I have been standing in the same booth, making eyes at each other, saying like, okay, we're going to get together next. And then all of a sudden I turn and Greg gets another person talking to him. And then I turn and I get another person talking. So we have to maybe meet up at the NCPA this year, 2024. It's going to be wonderful. Columbus, guess what? I don't have to fly for like once in my life to a national conference. Guess what I get to do? I get to get in my car and pack it up with whatever I need and drive to Columbus, Ohio for that event. So I'm excited.
That is great. And yeah, definitely looking forward to meeting face to face. Yeah, the last time I saw you in person, I was literally waiting in line to try to talk to you. But then things got crazy. So that'll be great.
See? All right. And the other star of today's show, Nikki, you have to introduce yourself. Tell us where you're from. We want to hear about the story about you and your community, how you're taking care of 400 very special people in a tightly knitted community, and also how you have become an inter-county delivery specialist, which is very special to this discussion today because we're going to dive into pharmacy deserts. So Nikki, take it away.
Okay, my name is Nikki Bryant, and I got my Doctor of Pharmacy degree from Marshall University in 2003. So I've been a pharmacist for 21 years.
That
I
went
worked
fast, didn't it?
Yeah, it did go fast. It did. It's kind of hard to even get it out. But the first job I had coming out of pharmacy school, I was 23 years old, and I came back to Richland, Georgia, to a 25-bed critical care access hospital to be the director of pharmacy. And that was kind of a laughing thing at with my friends, because they're like, oh, you're going to be a director of pharmacy, but I was the only pharmacist. So the only pharmacist in the hospital. And so I stayed there for several years, and I've had lots of experience in multiple chain pharmacies, nursing home consulting. So I kind of got beat down working for a chain, and decided that if I was going to give 110% of myself, I needed to do that in my own community. So I opened my first independent pharmacy in 2014 in Preston, Georgia, population 400. And they had not had a pharmacy in Preston in 60 years. So that was very exciting for my community. But I learned very quickly that I was going to have to get out of Preston somehow to gain more business to stay alive. So I started delivering. I was the only independent pharmacy within probably 30 to 40 miles with a delivery service. So we have a ton of elderly patients. And the whole theme here in my communities is really basically that, when children grow up, they go to college or move away, and then they stay wherever they go and they don't come home. So we have a vast population of elderly patients who are kind of just stranded here without support from family. So we kind of have taken all of those elderly people under our wing. And so we deliver now. I opened the second store in 2019 in Randolph County, which is about 30 miles from Preston. All of the counties around me are very rural, under the federal poverty levels. I think Randolph County, in an article just this week, was named the poorest county in Georgia. So we're talking about vast majority of elderly and underserved population. So I did open a rural health clinic in Preston in 2019. So I do have a rural health clinic, and so I have a nurse practitioner that's full-time there. So we go to people's houses to see that they get care and their medicine. So it's just become my passion to be sustainable here. Whatever I have to do, I'm going to do it.
And Nikki, I may be remembering this wrong, but you do so much in terms of like access to care for your patients. And I want to say, I don't remember when this was. I don't know if it was during COVID or not, but I mean, weren't you guys like running 4-wheelers to deliver to really, really rural patients? And like the 4-wheeler was like getting stuck in a ditch, or maybe it was an ATV. I mean, you guys go above and beyond to get medicines to people. Yeah.
My delivery cars get stuck all the time. I mean, it's a lot of unpaved roads here. So, it's like the wild, wild west out here. I mean, it just, I can just tell story after story about how we've had to overcome challenges here just to provide care. So, I feel like sometimes I'm on an island. I'm the only one on it, with all these people that need all this care. And so it's just a challenge every day to be financially sustainable in this market.
All right, Greg, Nikki, now it's time that was the softball questions. Now it's time to jump into this hard stuff. And it's something that we're all going through. It's a macroeconomical effect on the how do you say damn it. See, I shouldn't have. Disproportionate.
Tongue twister.
Yes. To the ability of being able to apply tax dollars to funded programs that get impacted by the way that the PBMs are now over profiting, and there's no balance between the amount of money that they're taking, and that has had a massive effect on having enough pharmacy care in communities that need the care, including the closing of chain drugstores that can't stay open because they've eaten their young. Their model
Right.
of reimbursement and how they play games, and we all know what that's like, has had a trickle down effect on on communities throughout the country. And in your county, in your area in Preston, Georgia, and where you're surrounded and how far away Americus is, which is a bigger community, but that's probably a hike. Looks like it's what, an hour away?
It's about 30 minutes if you're in town, but as you go into more of these remote rural areas, I mean, these people are 40, 45, 50 miles from any kind of chain pharmacy. And, you know, it's not like in Pittsburgh where you can jump on public transit and get to where you need to be. I mean, we have no public transportation here. So, I mean, these people, if they don't have a car or a way, I mean, they're homebound basically. So to ask them to drive 45, 50 miles to get to a chain pharmacy is just, it would take an act of God. Like, I don't know how they would do it.
All right, so Greg, let's open this up. Senate Bill 198. Tell me what happened. Tell me the impact that this is going to have on Georgia pharmacies.
Yeah, and if it's okay, I'll give you a little background to sort of what the catalyst to introducing this legislation really, really quickly. But what we found, and starting in January, all of a sudden there were massive issues with reimbursement in the Georgia State Health Benefit Plan, which of course you mentioned, tax dollars and taxpayer plans. I'm going to digress for 1 second. Nikki had one of the best lines I've ever heard in testimony in the Georgia State House. And Nikki, I might mess this up, but it was something to the effect of, my own tax dollars are being used to fund my independent pharmacy out of business, I think was the gist of it. But we found, again, it was like a live nerve. And, we had a pharmacy that was closing in a small town called Tate, Georgia. It's in North Georgia. It's in the foothills of the North Georgia mountains. And it was really the only retail independent pharmacy in this town. And it's a beautiful pharmacy. And this is a pharmacist who is engaged and, dedicated to finding ways to serve patients. And, she was closing her doors. And unfortunately, as we kind of discovered the issues, it was too late for her. And it was too late for several. I think by the end of March, we lost somewhere between 5 and 7 independent pharmacies in the state of Georgia shut down. I was in Tate Family Pharmacy. I was in Bell's Family Pharmacy in Tate, Georgia. I was there the day it closed, or the day before it closed. And it was one of the, I've been in the pharmacy business a long time, advocacy and in private practice representing independent pharmacists. That was the focus of my private practice. And I would say it was probably one of the saddest days I've ever been in, one of the saddest days I've ever had in pharmacy, to be in a community pharmacy the day that it closed. And, there were patients stopping by crying. There was a physician who is in that area, and he stopped by personally just to let her know how sorry he was to see the community losing that kind of access to care. So a physician took the time out of his day to swing by because he knew she was closing that day, the day before. But a lot of the pressure points for her pharmacy was in the state health benefit plan. And so we started to really drill down and take a look at it. And what we found was utterly stunning. First of all, we were able to access all the drug pricing data through a state portal. So we were able to access, hey, what are chains being paid? Each chain being paid. And we just started looking through the view of Bell's Family Pharmacy in Tate, Georgia. And so we started looking through that lens of, hey, let's pick the 3 closest chain pharmacies, which were a couple towns up in a town called Jasper, Georgia. And let's just compare it. And you may have seen a one-pager. There was a one-pager that went, I think, and probably with the help of Nikki, almost sort of viral. And a lot of folks all across the country have seen it. but it displays sort of the average chain payment compared to what independent pharmacies in Georgia are being paid under the state plan. Now, what a lot of people don't know is we did that average to try to be maybe intellectually fairer and to be less extreme, because if you look at the individual spreads, they were stunning. One of the first drugs we looked at was atorvastatin, and Bell's Family Pharmacy was getting reimbursed $1.90 for atorvastatin. If you go up the road a few miles to the closest chain, that chain was being reimbursed $89. So the highest chain payment was like 2,300% more than an independent pharmacy. And, so she's sitting there doing and then you go down the list and there's just more and more examples, 800% higher, 900% higher, 1,400% higher.
You think an attorney general out there that's aggressive, that really gets into this, and I know politics play into this, I'm not naive. So if this attorney general somewhere, hopefully in the state of Georgia, digs into this, this could be predatory. This could be like, data analytics is very powerful. Let's concentrate on a community that we know that there's 2 independent community pharmacies in. Let's price things around them so that they're at a disadvantage. Obviously this causes, issues, and then they close. Could something, I think something like that could be proven based on data and pattern.
Yeah, I think absolutely it's something that has to be scrutinized, right? Because I mean, these patterns, and let me say, when we were coming up with this one pager, going through this pricing, it was sick to my stomach, right? We all know that independent pharmacists are treated disparately. It's something that's well known in the industry. But when you dig down into the numbers, you can't look at these numbers, Todd, and not be sick to your stomach and not know just intuitively that something is wrong and that something has to change, right? Whether it's unfair methods of competition under Section 5 of the FTC Act, whether it's, failure to comply with MAC pricing laws and updating pricing. I mean, so it stinks, right? And I don't mean literally, like it stinks like a dead animal, and people need to look under the rocks. And I think because of if you have any sense of fairness and you look at this, I mean, that's all you need to see to know the system is broken. And our Georgia independent pharmacies, it's like they're trying to stay afloat with a 2,000-pound albatross around their ankles. If you read the annual reports of chain pharmacies, they're talking about their reimbursement struggles and how hard it is for them. You alluded to chain pharmacies closing, right? These independents are getting paid thousands of percent lower, hundreds of percent lower. And here's the important thing that I want to make this point. These are not cherry-picked drugs. We looked at like the top 30 most commonly prescribed generic drugs, the drugs that independent pharmacies are filling every day, right? And chain pharmacies are filling every day. And so the impact to independent pharmacy, I mean, it's just absolutely crushing. And when these numbers were revealed, it was a catalyst to real momentum. These numbers were, Georgia starts its session roughly the second week in January. Nikki, jump in here. I think we discovered sort of this issue, this problem, maybe around mid-February or early February. Right. And so
I think,
so,
when Katie announced she was closing, it was just like, well, we're all struggling that way. And, you get, I think every day, like when you're in the trench and you're working every day and you're doing everything you can to just survive, it just becomes so commonplace to see negative reimbursements. I mean, it's continuous all day long. And so nothing really stands out to you as being abnormal. Isn't that terrible that, negative reembrsement is it's just a normal thing now. And so, when Katie said she was closing, it was completely devastating. And when someone dies, you automatically relate it to yourself. Like, what if that were my mom, or what if that were my dad? But you think, what if that were my pharmacy? Like, what would my patients do? And it was just completely devastating.
Yeah, and it caught, and it stuck in the throat for people. I don't know, Todd, if you saw this or not, but there were some Georgia legislators who got up in the well in the Georgia House to speak on behalf of independent pharmacists. And the state representative, who's just a great man, great representative in Georgia, who is the representative for the district where Bell's Family Pharmacy is, I mean, he got emotional in the well. He got choked up. It's something that resonated, and it was something, these numbers were so stark that it just compelled action. And the General Assembly was just, awesome. In the Georgia House, there was a bill introduced, and this is a different bill, Todd, so it gets a little weird. But there was House Bill 1363 was introduced about a week before crossover day. And for folks who may not know, crossover in Georgia is the day that a bill has to make it out of its originating chamber. And it's really hard to pass a bill. I tell this people all the time, you could try to pass a bill that says puppies are cute, and there's a good chance that bill dies. And so this bill got introduced about a week before crossover, which means it had a week to make it out of the House and over to the Senate, or else the bill is effectively dead. And the House made this bill a priority because they wanted to fix it. And HB 1363 was I think a really important bill, because it didn't just look to protect independent pharmacy alone. It looked to fix the system. Because think about it, every time a teacher's paying $90 for a torvastatin, and where independent pharmacy is getting reimbursed too, that teacher's getting, they're getting ripped off too, right? They're paying $90 for a drug that maybe should be $30 or whatever the price is. And so this bill would have required the state health benefit plan. The bill looked to do two things. One, do an actuarial study, and if it showed cost neutrality or savings, the state health benefit plan would have been required to move to a NADAC-based model. So NADAC plus a dispensing fee, which is really, really important because we think that it has the potential, A, to greatly increase transparency, B, save the state money, and C, pay independent pharmacies fairly. So it's really good policy. And as long as the PBMs continue to set drug prices, what we've seen is pick the game, right? Spread pricing and where they're reimbursing the pharmacy low and charging the state or the employer high. DIR, where they're reimbursing the pharmacy high and then clawing back, lots of money on the back end, right? Pick your poison. If PBMs can continue to set drug prices, PBMs find a way to win, independent pharmacists lose, patients lose, taxpayers and employers lose. But so that's what that bill would have done. And that bill made it through the House by crossover. And ultimately that bill got killed in the Senate in a Senate HHS committee hearing, and under the auspices of, hey, we don't have a quorum, we can't get the vote. However, there were a lot of folks in Georgia, particularly in the Department of Community Health, who, lo and behold, were not real supportive of that bill. And so the next bill, the bill that got to the finish line, SB 198, was really a very quick audible to try to ensure fairness, sustainability, and parity for Georgia independent pharmacists. And that one wouldn't have changed the whole system, but it was a really common sense bill. Hey, you can't reimburse our Georgia independent pharmacists less than the average you reimburse a chain. And that's the bill that ultimately there was a fast pivot, and there was a lot of momentum. That bill passed the House on the last day of session. We call it sine die. It passed the Senate on the last day of session. And then, of course, ultimately was vetoed.
So I'm an inquisitive guy. I need to know from insiders, and not to spawn or to fuel any conspiracy theories, but what organization has been involved with the state on whatever level in the realm of, pharmacy insurance, for example, maybe a PBM, that would have made such an influence? Or what is the dominoes that now are going to fall based on this decision? Because we already know that there's a pharmacy desert issue. We have a population that's going to be hitting 340 million here in the next probably 24 months. Okay. So that's going to happen quickly. We have an influx of having to take care of people that have come into the country very quickly, and the infrastructure. So as I said in our opening, Greg and Nikki, we need more pharmacies, not less pharmacies, right? And we know, based on the ripple effect, we discussed this before we started recording, that the impact of the collapse of independent community pharmacies as well as chain pharmacies on communities, we haven't even seen the height of what that problem is going to cause, because the pendulum already has, economical momentum on communities, and how bad communities are going to suffer because there's not enough pharmacy services. There's not enough medication management reviewing. There's not enough medication adherence. I mean, public health is going to take a square punch right in the nose over the next 3 to 5 years, where we see an improvement
Absolutely.
because of the impacts of what the PBMs have done.
Yeah, I can tell you, we have some on public exchange, on the insurance exchange. There's only a couple of plans available in this area. And like I said, a lot of my population is low income. So most of the people that have these exchange plans qualify for the full kahuna. They don't have to pay premiums. They don't have to pay copays. And what we're seeing here in this population, and you talk about all of these, the influx of all of these people, which would probably qualify, eventually for these services, but all of these plans are reimbursing at a negative margin, and they are all PBM affiliated plans who have, there's lateral integration. So the PBMs own the insurance companies on these exchange plans. And so, why can't we all be friends? There's plenty of business. There's plenty of us all to do for us all to do. Like, and whenever I see these plans, when I'm reviewing refills for patients, I do that on a weekly basis who needs a refill. I can honestly say that I am a lot more motivated to care, to fill, to make sure people are compliant on a prescription that I at least break even on, in comparison to one that I'm losing money on. Like I care about the patient, but I can't continue to fill prescriptions that I lose money on. So if I'm paid fairly and I'm kept in business, then I can take very good care of people. But we cannot continue with these plans that, we're negatively reimbursed. We just can't. You can't do business that way. So there's enough business for everybody. There's enough work for everybody.
And there is absolutely enough business for the population expanding as it is and the needs that we're going to have. By the way, 11,000 new 65-year-olds every day in 2024 are turning 65. So think of infrastructure, and they're 70, they're 80, they're 90 years old, they're living longer, and they're going to need more services. Yeah. What's going to happen with, we already know the pendulum's coming and it's not going the right way, it's going the wrong way. We know that the infrastructure needed for long-term care pharmacies and long-term care at home and people going into the homes and caring for, so then we forgot the care part of this. Nikki, 400 people very well. Their allergies, their temperaments, probably the gossip between the families, but them as people, and you take care of them as people, as an expert in medication safety and management. And that's the way it's supposed to be, but I'm not naive. And you go into the inner cities where there's millions of people. So we absolutely need chains. Like we need chains.
Exactly.
And we need,
I'm not denying that for sure.
Specialty pharmacies that focus on specific rare diseases. Greg, what are the alternatives? Because I'm going to throw some things out here just for the listeners to chew on as they're listening to you. Take a stab at this. Two things. Number one, the rise of the PBMs that are fueled by pharmacists and are empowered by community pharmacies, and these benefit groups that are popping up, RX Preferred, True Scripts, the Fields family, which one they call it, APRO-RX, like these PBMs that are sprouting up in transforming communities by giving control back to the school districts, back to the small employers. There's some good efforts happening with people like Jeff Malone running RX. Yeah. Just got done talking with him. But then I'm going to flip another thing. So I want comments from both of you on the next gen PBMs, customizing healthcare for communities, like literally customizing how this thing has to work. And then the other one, which is the wild card, are the Kyle McCormicks in Pittsburgh, Pennsylvania, who are now 100% in control of his own destination. He's 100% cash. So if you took 400 people that you care for and you find out what the cost could be to them, and I know people are, it's hard because we're in hard times right now, but you could figure out how much money that is based in cash and then begin to build these co-ops with other organizations that are ready to fuel this. I see a whole nother generation of pharmacy coming to communities that need it to happen because it has to happen. And being able to create communities that really go back to the old fashioned times where the community was the insurance and it was funded by the community. And hospitals are starting to go that way too, and becoming private again.
So, so glad you brought that up. And I think obviously there's a lot of different angles to take there. But what I would say is, one of the signs of this system being in many ways, for the large PBMs, I would posit just irretrievably broken, right? And we haven't talked about it, but as in community pharmacies are being massively under reimbursed, the truth is in that same plan, we identified, drugs that are quote so-called specialty drugs that have 10,000% markups above NADAC that PBMs are paying themselves, right? And so when you look at like Blueberry Pharmacy and Kyle McCormick and the work that he's doing in unplugging from the system, really powerful thing, right? Now that's not something that necessarily every pharmacy can do, but by cutting out the large pharmacy benefit managers, by cutting out the insurers, and look, a lot of people talk about cost plus drugs and they're getting a lot of attention with Mark Cuban and he's doing some great stuff too. But I would say, Blueberry was doing it already, right? And showed a path forward where hey, when you cut out all these large, massive, Fortune 10s, Fortune 15 companies who are just getting their cut from every single side of the equation, pharmacies can be paid fairly, the drug price can be transparent, it can be stable, and the price for patients at the counter is far lower without the PBM setting and making up, I would argue, essentially making up these prices as they go along to benefit them. And the more and more we study the issue, the more we see that large PBMs are literally making drug prices up, right? So then there's lots of great 3-axis studies out there that show, hey, same drug, same pharmacy, same PBM, same day, price points between $500 and $90 for one drug. And over the course of a year, when a NADAC's unchanged, massive price points from a couple of dollars to a couple of $100. PBMs are manipulating drug prices to their benefit, and I would argue society's detriment. So love to see folks like Blueberry Pharmacy do the work that they do, and not only is it good for patients, but I think it guides good policy and how drug prices can be set, and that there is a better way. And I think on top of that, you're starting to see transparent PBMs pop up, right? You mentioned RX Preferred, and they're part of another organization called Transparency RX that's based out of DC. I don't know if you heard of them yet, but they're doing some really neat work serving as kind of a counterweight to PCMA. When you see the large PBMs come and say, hey, anything you do is going to cost tons of money, and then you have a transparent PBM that comes in and they says, hey, guess what? Transparency, we're doing it now, and it's not costing money. It's saving employers money. It's saving counties money. It's saving cities money. And so
it's still profitable.
Right. And it's still profitable. And to the extent that community pharmacies were very much the canaries in the coal mine on PBM practices, on vertical integration, on cost to the healthcare system, we're starting to see other folks, eyes get open. And it's great to see transparent PBMs come on the scene. It's great to see what they're doing for clients, but it's also great to see what they're doing from an advocacy perspective to help affect that change. But the result of this veto and other issues are, ultimately more pharmacies are going to close. And something that stood out with me to me is one of the pharmacies that closed during session was called Young Brothers Pharmacy. It was in Cartersville, Georgia. It had been open for over 130 years. And in his statement, one of the pharmacy owners said, hey, we survived the Great Depression. We survived and kept our doors open and cared for our patients during, World War II, the Vietnam War, right? We were able to withstand all of that, but we can't withstand the current reimbursement conditions and practices of large PBMs. And so, we're certainly not deterred and happy to talk more about some of the detail, but we're obviously going to continue to try to fix the system, to try to keep independent pharmacy doors open, but also fix the system for everybody. But to your point, and I wish I don't know if I can share, and obviously since this is the podcast, folks couldn't see it, but I've got a map of, there was a really good study done and a map of kind of rural, or I would say pharmacy deserts in Georgia, right? And a lot of them do happen to be in rural, although interestingly, you can also have pharmacy deserts right smack in the middle of a city, right? In underserved, low income areas as well. But Georgia's in trouble, right? I mean, there are a lot of.
Show us that map.
Okay, let me see if I can.
Yeah, and if you're driving, if you're in your car, if you're walking and you're listening to this podcast, you can watch this. Just go to Pharmacy Podcast Network and on YouTube, you'll find it. But yeah, this is interesting, Greg.
And so Nikki's probably laughing because this may be the first
I'm
thing.
so proud of you.
I pulled it off.
So proud of you.
This is the first successful attempt at ever doing like anything like technology related on the fly. So
Magic of This Week in Pharmacy.
So good.
This is a first, folks. But when you look at this map, it's scary, right? I mean, there are large swaths of Georgia where you've got rural pharmacy deserts. And the thing is, more pharmacies are going to close, unfortunately, right? We're trying to get help to these pharmacies as quickly as we can. But, one of the things is there's a lot of pharmacies out there in Georgia, but also nationwide, that are holding on because they're holding out hope. And when you get a bill like that gets vetoed, man, it makes some of those folks maybe not be able to hold on quite so tight. And maybe they slip off and lose them. And it's not just, obviously it's sad for the pharmacists. But again, in Bell's Family Pharmacy, I was in there the last day with patients in there, and the patients are crying, right? Like this is a crisis, not just for independent pharmacy, but it is a crisis for access to care, and it is a crisis for patient care. And when you look at this map, and Georgia's probably not much different than a lot of states, right? But as you get outside those metropolitan areas, all of a sudden you start to, their definition in that study is, anything exceeding 10 miles ultimately becomes a pharmacy desert. And you start to look at that map and holy mackerel, there are large swaths of the state of Georgia, particularly rural Georgia, that are in those pharmacy deserts. And the pharmacies that are there, even where you see the green in this map, like where there isn't a pharmacy desert, a lot of the time in Georgia, it's pharmacies like Nikki's, right? That are holding on, fighting, scraping, clawing, and Nikki's community relies on her, right? But she's having to be creative. And Nikki, I'll kick it over to you here, right? But you're having to do everything you can to try to keep those doors open, because state dollars in Georgia, they're caring for patients in the state of Georgia and state plans is a losing proposition, and that has got to change.
Yeah, I'll tell you, 2 years ago, I kind of saw the writing on the wall with, the whole DR situation, and I was just tired of just barely making payroll every week. And so I decided to open a coffee shop in one of my pharmacies in my Cuthbert store. I got an espresso machine, I have ice cream. And so a lot of my time is not spent as a pharmacist now, but I bake. Like I bake cakes, I bake cookies, I bake muffins. We have, coffee, and I can literally sell a cup of regular drip coffee and make more money on a cup of coffee than I can on a prescription right now. And, it's really helped to sustain me, but it should not be this hard. It should not be this hard. Like I should not have to do all of these things just to try to keep the door open.
And the reason she's doing it is because she cares about her patients, right? But you shouldn't have to sell coffee to be able to care for patients, right? The system is misaligned, the incentives are misaligned, and my God, and Georgia in many ways has done some really significant stuff in pharmacy advocacy, PBM advocacy. In 2019 was the first steering law in the nation. We're having massive problems with enforcement with that law. But some of the pharmacies, really most passionate advocates who would come down to the Capitol and who would fight, a lot of them are gone, right? A lot of them are tired because, you know, they spend their days and their hours and their weeks and their months behind a counter, you know, getting pummeled on reimbursements. And, you know, they get some hope, you know, maybe a bill passes here, maybe there's some good news federally there. But at the end of the day, no matter what we've done, you know, the conditions remain unsustainable. And you get this fatigue. And so many of our great advocates, they're not there anymore, right? They're not coming to the Capitol. They're not, right? They've been exhausted. They've been forced to close their doors. They've been forced to go into different types of businesses. But, you know, Nikki and I have been kind of fighting this fight together, you know, for a long time. And Nikki, you know, is still has punches yet to throw and is still passionate. But my God, you know, the only pharmacy in a community, you know, the healthcare hub in a community, and you've gotta serve coffee to keep the doors open because of underwater reimbursements. It's wrong. And, you know, pharmacists are really polite, and they're some of the nicest people, you know, that there are, right? And they're leaders of their communities. They're of the hub. And a lot of folks don't, you know, they say, oh, you know, it's bad taste to talk about reimbursement, or it's bad. Listen, like it is beyond time. Every fight that pharmacy needs to have now, independent pharmacy, that has to be part of the conversation, because if pharmacists aren't being paid a sustainable rate, they're not going to be here, and the patients aren't going to be cared for.
Yeah.
Yeah, unfortunately, that's going to be the we're going to hear this on the national news. We're going to hear it on the local news. We're going to hear it on state organizations that there's people suffering. This is going to be a public health crisis, and it already is, and no one sees that we're coming up into this, like I said, into this wave, and the wave hasn't even crested yet, based on our infrastructure needs of where pharmacies must be positioned to take care of people that have you know, high chronic needs for the conditions that they're going through, and oversight, and you know, so that's where I kind of want to shift the conversation to both of you for some creativity. Remote patient monitoring services to be reimbursed. I'm not sure where we're at with that, but I want to see more creativity coming out of technology per se. And I want to know what you guys have heard about remote patient monitoring, as well as technologies like delivery systems. Like there's a company called RxMile. RxMile has this whole infrastructure ability to become a delivery service of independent community pharmacies services, and then they can become kind of like a delivery organization as well to take people to their doctor's appointments, and it's all serviced by this partnership with community pharmacies. But talk to me about creativity and in technology, and how it might help. It's still going to be an issue, but we got to leverage tech to make up some of it.
Yeah, RPM is I've been down that road. Like I said, I own a rural health clinic, and we did RPM in my clinic for a good solid year and a half. And we were, you know, these companies will provide all the equipment for you, and then you just have to bill out the codes. And then the codes are reimbursable, and then you owe them the equipment reimbursement. And so I was paying into this company for the equipment. We were doing it. And about a year and a half in, I realized that we weren't being reimbursed for the actual service, and that rural health clinics actually do not qualify. If you're a rural health clinic, you don't qualify for reimbursement through RPM. So that was a very expensive lesson that I learned about RPM. But if you're classified as a rural health clinic, you cannot bill for RPM.
Wow. Well,
which is interesting, because these are the clinics in the communities that need RPM the most.
Right.
But a regular clinic, I haven't heard yet of pharmacies doing RPM or being able to reimburse for RPM. I haven't heard anything about that. Greg, have you heard of anybody being able to set up for RPM?
You know, I definitely think that there's, you know, as time goes on and technology evolves, there are going to be opportunities, and there's certainly like a few, like, there's some Part D CPT code, or there's some Medicare CPT codes, not Part D, but Medicare CPT codes out there where pharmacists can collaborate with physicians. And, but what I would say is what's out there now is spotty, right? Like I do a fair bit of work on this from a policy perspective, and I think it's really important. But what we've found, unfortunately, is when you start talking about patient outcomes and pharmacy consultations, et cetera, the truth is that it's been leveraged more in a way, technology has been leveraged more in a way to make patient care punitive to pharmacies than to reimburse pharmacies for the care that they provide, right? And this may be a bit of a digression, so smack me back into it. But one of the warped things from my perspective when you looked at like DIR fees is so much of that was tied to patient scores, patient consultations, patient metrics, patient adherence. And ultimately, what in practice, what it did is they tied the reimbursement of a drug to these sort of amorphous patient outcomes or amorphous patient scores. And they used it, A, to manipulate drug prices for pharmacy, and B, to basically shift the burden to patients. So what happened is patients are paying much higher copays, much higher cost shares, not getting the benefit of any, quote, discounts. And then after the fact, the PBMs are clawing the money back from the pharmacy on the grounds of patient outcomes, patient scores, patient metrics, which is really sick when you think about it, because all the data's out there show that the higher the price of the drug, the reduced adherence and the poor patient outcomes. And what DIR effectively did is it empowered PBMs in Part D to raise the price on the patient at the counter and then take that money back later, all under the auspices of patient outcome scores and metrics. So to me, a big focus of pharmacy policy should be that insurers and PBMs and payers cannot tie the price of a drug, the ingredient cost of a drug, to patient outcomes, to patient scores, patient metrics, right? Independent pharmacists should be paid for their consultation. They should be paid for their expertise, and technology should be leveraged to help them do that. But right now, technology is leveraged really to steer patients outside of pharmacies and then to tie the ingredient cost of a drug in a punitive manner to take away from pharmacies. And, again, I just think that's unfortunately where we are. But I do think, to your initial question, I think there's opportunities, and I think those opportunities are certainly have the potential to improve health outcomes and pay pharmacies fairly, but I just don't think we're there yet.
Yeah, I think it's always been my experience with metrics. It's so frustrating because you can have great metrics and you would think, oh, these PBMs are going to reward me because my patients are so compliant with their medicine and their treatment plans. But then it's not rewarding me. It's just taking back less from me. So there's never a reward. It's just we're not going to take back as much as we would have if you didn't take care of the patient. And so it's just so frustrating in that aspect to see these scorecards from a PBM and say, oh, well, we're only going to take $12,000 back for this trimester. And if you didn't care for the patient, it could have been $40,000. So, it's just, it's very discouraging at this point by just, the games we play just to break even.
And pharmacists, I say this, it's funny, it's sad, but it's, say it a half in jest, but pharmacists give away more of their expertise than any profession that I've ever seen, right? And now keep in mind, I'm coming from the legal profession. So when somebody picks up a phone, the attorney's billing for every minute that they're on that phone, right? But I mean, my God, right? The consultations, the delivering, the opening up after hours, independent pharmacists give away more of their expertise and time than just about any profession I can think of.
Yeah, my heart bleeds. Like if a patient calls me late at night or, I'm already in bed and I get up and get dressed and go to the store to fill a prescription for their child that's been to the ER, and then I run their prescription through and I lose $15 on it. I'm just like, why? Like, why? Like, why did I even get up? But yeah, it's just.
But you do.
I do. I still do. Like, I still do it. I don't know why, but I still do it. I guess just because I love my people. But yeah, it's there's no reward for anything extra in this field. And you just get penalized less if you do good.
And so I guess, and this is a roundabout, I guess, answer to your question, Todd, but I guess where I land is, as long as PBMs and insurance companies and payers indirectly are, and again, I think it's being driven by the PBMs and the insurers, but as long as they can use patient outcomes and technology as a stick, they're going to continue to do that and not pay for pharmacy services in the way that pharmacy deserves.
Yeah, there's been a lot of conversation on social media, Amazon starting to deliver medicines with drones. And, I kind of laugh at that because I can just see an 85-year-old patient who lives in the middle of nowhere on a dirt road. I can see a drone land in their yard and only imagine what would happen. I just don't.
Or they're going to shoot them out of the sky.
Yes, they would probably pull the shotgun out and it would be done. So I just, patients here, they expect a person. I mean, they expect a personalized care. Our delivery drivers are, we find all kinds of situations. I mean, we had a delivery driver who came up in the yard. There was a hospice patient completely unclothed in her yard, beating a tire with, a hammer. And it was just, the driver found her and obviously called the pharmacy and was like, what do I need to do? And so we got the lady help. And, but a person needs to be handling people in that aspect. And I don't see how that personal connection can be replaced by a drone. I just, a drone can't detect what's going on. Yeah, we have a lot of social determinants of healthcare that we identify when we're actually, interacting with people. So that's another topic in itself. So.
Yep. Well, we are out of time, but I want to invite our listeners to reach out to either of you. Do you have a preferential way of reaching people that want to connect either through LinkedIn or through Instagram? But give us something that the listeners can reach out.
Yeah, I have Instagram and Facebook. It's Adams Family Pharmacy on both platforms, and you can find me on LinkedIn, Nikki Adams Bryant. But I really appreciate your time and just exposure of what's actually happening in independent pharmacy in Georgia, and appreciate you having both Greg and I on.
Absolutely. Greg.
Yeah, and I'm available on LinkedIn, Greg Reibold. Also, email is a good way. Greg R at apcinet.com. I am on Facebook, but I'm spotty on Facebook. Nikki laughs at me, right? But so that's probably not the best way. But email or LinkedIn is a great way to connect for me. And again, really do appreciate you shining a spotlight on what happened to Georgia, and we're going to obviously be keep working to find a solution that's good for independent pharmacists, patients, and ultimately the state as well.
Well, we're going to have you back, Greg. Nikki, we'll have to have you back as well as a follow-up. We'll talk about more on This Week in Pharmacy. So, hey, This Week in Pharmacy, today's episode is brought to you by IPC, Independent Pharmacy Cooperative. We love working with them. They're owned by independent community pharmacies. And really, that is today's theme, is the strengthening of our independent community pharmacies.
This episode is sponsored by Independent Pharmacy Cooperative, widely known as IPC. Established in 1983, IPC is the nation's largest group purchasing organization owned by independent pharmacy. With a mission of maximizing the success of community pharmacists, IPC works to provide members with access to effective programs and services designed to enhance profitability for independent pharmacy. Read more about our mission by checking out our website at ipcrx.com. That's ipcrx.com.
Hey, and on our second half of This Week in Pharmacy, we're talking technology. Imagine technology that's intelligent enough that you take a picture with your phone, a bag, a handbag, a tablet, some kind of pill, some kind of coin, and imagine that the technology tells you if that object is really authentic and if it's fraud or not. Like, that's crazy, right? You have to listen. Coming up now, Alitheon's CEO on This Week in Pharmacy. Hey, you know what? Anybody listening right now, pharmacists, pharmacy technicians, people in business of pharmacy, the world of authenticity, understanding if a medication is what it is. I think of our wholesale partners. I think of our pharmaceutical manufacturers. I think of authenticating ingredients that are coming in, the tablets, of the way that they look. There are pharmacy management systems that tie into pharmacy automation and packaging systems that have identification technology embedded into the systems. I think of Icon, for example, that takes multiple pictures of a medication before it's packaged, and how important it is to become an authorizer and a trust agent of identifying what is real and what is fugazi, aka false. And I am so excited to introduce Roy Genzarski to us and to our This Week in Pharmacy listeners as a source of that. The word today, the key word today, is authenticity and identification. Roy, I want to thank you for being on This Week in Pharmacy.
Thank you very much. I'm excited to be here.
So, wow, watches, automobiles, there's so many facets of what your organization has done, the technology that you bring to the table. This is fascinating to me personally. Would you tell our listeners a little bit about you and your organization? And why I'm so excited is you've developed a technology to really be able to tell what is real, what is fake. In the world of healthcare, fake and real is life or death. So talk to us about your technology and your organization.
Absolutely, and I appreciate that. And by the way, it's not just fake and real, it's also right and wrong. And we'll talk about that here in a second. But so I lead Alitheon, and we are a company that, in essence, fingerprints things. If you think of fingerprinting and why the government likes that with people, it's because you don't know that you want to rely on someone's driver's license, a badge, a passport, all sorts of documents that could, of course, be manipulated, faked, forgotten, given to someone else. I mean, imagine twin brothers wanting to cheat on a test. What easier way to do that than one shows up with the other's driver's license and says, oh, it's me, and I walk into the classroom. But if you want to make sure the person is the person, you go to their biometrics, their fingerprints, because even twins or triplets, by the way, have different fingerprints. And so that's why governments like fingerprints. They're unique and they're persistent, right? They're part of us. What we have developed is a way to find the fingerprints, quote unquote, we call them feature prints, of every made product. And every made product has them. They're already part of the product. You don't have to add any proxy or nonsense like barcodes, QR codes, NFC tags, invisible ink, DNA markers. I mean, there's so many ways to add a proxy, which is no different than a driver's license for an underage teenager that can be faked so they can walk into a bar and grab a drink. So what we've done is say, how do we mimic that idea of embedded, ingrained, already existing fingerprints to things? And that's what we did. We are able to take a picture of things, a single picture, and serialize them. And by serialize them, meaning we can identify the individual items that we're taking a picture of. Not, this is a phone, but rather this is Roy's phone. Not that is a black cat, to use the example, but that is Roy's black cat. So really the identification, just like fingerprints are for humans. And when you're able to identify at an individual level, the one out of the millions, what does that mean? That means, one, you can trace them wherever they are. Who's the last person that saw them? Where did they go? Supply chain, etc. That means you can also get rid of fakes, because if you're the manufacturer and you are feature printing, i.e. fingerprinting every one of your products, then anything that can't be identified by definition is fake. So you get rid of the fakes, but you also take the next level. You get rid of gray market and diversion. A lot of the issues that pharma faces today, as do, by the way, other industries, but in pharma, it's so easy to do, is gray market pharma. I take medicine that's expired, and then I erase the date and print a new date on it. And all I have to do is mess with the box. I don't have to deal with the pills or the vials or the syringes. I just change the date on the box, and I have a brand new product I can peddle, and people will buy it. Happens all the time. Happens also in medical equipment, by the way, things that go to surgery, all sorts of supplies for the OR. Expired, people erase the date, put a new date on, and sell it. Now, any traditional anti-counterfeit system won't work here because these aren't counterfeits. They're real, except they're being sold illegally against company policy, etc. So we will catch that as well, because if I'm able to identify each individual item, I can know, hey, that one had an expiration date of January 20th. So even though the box may say expiration is August, it doesn't matter. I know the truth that the actual thing is telling me. And then the last thing we can do when you can identify items is eliminate human error from misidentification. And maybe two pills look alike, maybe two vials look alike. I'm stressed, I'm busy, I picked the wrong one, the wrong bag, the wrong box, whatever it is, and I hand it out. No ill will, no malintent, right? No fakes, nothing, just wrong item. Happens all the time as well. But if you can identify them simply by taking a picture, that changes the whole story. And so that's what we developed over about 5 years. And today we go to market in quite a few industries where what we call high consequence exists. Think of car parts like brake pads, airbags, and so on. Airplane parts, of course, medical pharma, Department of Defense, Department of Energy, things where if you get it wrong, it's not just about money, right? We're not talking about the proverbial Rolex watch or Louis Vuitton bag that you get on Canal Street. We're talking high consequence items, and that's what we focus on.
That's incredible. What's funny is, and it's a testimony to what you've built, Roy, is the fact that you've been awarded Best Inventions of 2023 by Time Magazine.
Yeah, that was really cool.
I love the feature print description. Please, for our listeners who might not be looking at their screens right now, if you're on YouTube, you'll see the screen that shows you Best Inventions 2023 for Time. But if you're just listening, talk to us about what is feature print.
Yeah, so feature print is basically the fingerprint of the things. Call it feature print because we are basically looking at the prints of the features that are on the item. Just like fingerprints that are embedded on our fingers, that's why they're fingerprints. The feature prints are basically all of the, you can call them features, aspects, flaws of the manufacturing process that exist on every single item made in the world. If you think of manufacturing and you just read quickly on a Google search, what are tolerances in manufacturing? Basically, as human beings, we figured out that when we went from all handmade things to the Industrial Revolution, we figured out that machines could help us be way more productive. I can make more of these cups, medicine, etc., in a machine than I could ever do handmade. But what we also figured out is that machines really can't do the same thing over and over again. They do things really, really close, but they're not the same, which is why engineers give the idea of tolerances. Hey, I need this pill to be 2 millimeters wide, plus minus 1/1000. I need this vial to be 5 centimeters long, plus minus 200ths. Why? Because as long as you're within that, you'll hear a lot about 6 Sigma. As long as you're within that 6 Sigma band, you look the same, you act the same, you perform the same. For all intents and purposes, you are an identical item to what you need. What we have developed is a way to look inside that band at all of those little nuances that, while human beings can't see, are there because of the process. And because they are not designed, they're random and chaotic by nature, they constitute the equivalent of a fingerprint for a person. We call it a feature print. Now, knowing that isn't the magic of Alitheon, right? Everyone knows about the 6 Sigma, the tolerances. It's the fact that we can do it with a standard off-the-shelf camera. We don't need any special camera, no spectral imaging, X-ray, infrared. We can use a cell phone, in fact, to do this. That's one. Two, I don't need to know what the item is. There is no system training involved in, show me 1,000 of these vials, then show me 1,000 fake ones. And in vial 2001, I'll tell you, hey, I think this is real or not. No, we start taking pictures and immediately can tell you, the identification of each. So that's the second part. The third, we literally don't need to touch the item. No adding of anything. No barcodes, no overt, covert, secret dust, nothing. Just a picture from a cell phone or industrial camera, and you can serialize your products.
This is incredible. This is incredible because you're reaching where it's needed at the place that it's needed instead of asking someone to go to some kind of facility and bring the material with them or the items with them. You're bringing it to that organization, aka maybe even the drug manufacturer. And I think of our pharmaceutical industry and how important ingredients as well as the end product becomes, and how many fake issues there are with receiving medications, tablets, pills that are not what they're supposed to be. And if they had this technology, how we could divert so many of those issues that are coming up.
I mean, I just think about one as a person that takes all sorts of medication when required, and a father of just recent stories that have happened. Gilead finding millions of fake HIV pills being sold. The recent Ozempic in Europe, right, where they had hundreds and thousands and hundreds of thousands of these Ozempic syringes, fake ones, being sold in the market. All, by the way, with real package, anti-tamper, anti-counterfeit markings. The challenge today in most of the pharma world is that everything relies on the package and some sort of marking on the package to tell you it's real. There's a super secret barcode, a QR code, invisible ink that tells you the box is real. I don't care about the box. I'm taking a pill. I'm not swallowing a box. The box isn't what's going to kill me or make me sick. It's the thing that's in the fake Ozempic pill or a syringe. It's the thing that's in the fake pill. It's the lace pill. Those are the things that will kill me, not the package. So why is there so much focus on the package? Well, most of the pharma world uses proxies, and you don't want to add a proxy, some sort of added thing to the medicine that you put in your body. So you add it to the box, but the box means nothing. That's why I'm so excited about what we do is we actually protect the item itself, not its packaging. Now, you want to link it to the package? By all means, we can feature print the pill or the Ozempic syringe, and we can then feature print the box that it comes in and link the two together. So you could be a pharmacist, you could be the consumer, take a picture with your phone of the box and it'll tell you, yeah, that's a real box. By the way, inside of it should be syringe number 12345. You pull out that syringe, take a picture of it with your cell phone, and it'll tell you that is in fact syringe number 12345, or hey, this isn't that syringe. So whatever the box says, don't use this syringe because it's not one that came from the manufacturer. So to me, the exciting part is the fact that we have now thrown away the need to have people trust a box or a bag and rather trust the medicine itself.
I think of Noritsu, I think of Parata, I think of the world of AutoMed and RxSafe. I think of all of these technology companies who are in the business of packaging medications for the last mile, aka last inches between the organization, the prescriber, the packager,
and the patient.
And the patient. And I think of where you fit in, and that has to happen to be able to identify. And those are the organizations that I shout out to during this podcast is how are you assuring that the medications that are being packaged and given out to your patient that are being taken every day, are you sure? Are you betting people's lives and well-being on, your technology?
Yeah. Are they the way we like to describe it is, are they real? Are they legal? And are they correct? Right? If you can answer those three irrefutably, you solve the problem. And to your point, the more we've gone now digital as a world, right? Less and less people walk into a physical pharmacy, into a CVS or a big name pharmacy where, most likely things are okay. More and more things are happening online. Even the pharmacies are buying online. And so there are less human interactions for me to look at the person selling it and say, hey, you look a little suspicious. Maybe I don't want to buy from you, regardless of whether it's real or not. I want to eliminate those red flags. Those red flags are gone because of the interaction that's now been minimized to a website. And any person, good or bad, can set up a website that looks like a legitimate pharmacy. So again, we focus not on the website, the pictures, that we focus on is what you're about to take, what it's supposed to be. And all with a picture.
Has Alitheon approached government agencies and saying, hey, this is a protection of public health?
We have talked to various agencies, which shall remain nameless. And usually the response is, well, you know, we can't force people to use the technology. And I agree 100%. No government agency should ever say, oh, you guys should use Alitheon. But what they should say is, you have to prove to me, the government agency, and to your consumer that that physical item is what it's supposed to be. And not say, why don't you check the barcode on the box?
Yeah.
And if that says it's real, that's okay. Or why don't you check the paperwork? No, that is no longer good enough because bad people have found really easy ways to circumvent that. We have to have the government agencies regulate and set policy. That's the one thing they're supposed to be good at. And the policy should be deploy something. Maybe it's us, maybe it's some other technology, but deploy something that says, I have checked the actual medicine and the actual syringe and the actual vial, not the package that it's in.
Yeah, the packaging can always be fake. It can always be manipulated, but the actual substance is what Alitheon is concentrating on. I think that's the differentiator.
Absolutely. In fact, the package could be real with fake contents in it. How easy it is to go to any recycling bin and pick up a bunch of empty pharma boxes and pharma bottles. Pick them up out of the garbage, out of the recycling bin, go behind any pharmacy and pick up the things that they're throwing out. And I just fill them up with whatever I want to. And suddenly I could be a pharmacist because the reliance, and it's all with real packaging. So we have to get away from relying on packaging. It's the same message, by the way, and the same deployment we do with aerospace, with car parts. The fact that a brake pad on a car has a nice anti-counterfeit hologram sticker on it means nothing. It just means it's a nice hologram sticker. Check that the pad itself is what it's supposed to be, or you could die, and things have happened.
That's nuts. I'm excited about this technology. I see that the pharmaceutical manufacturers should definitely be investing in this with a organization that says, hey, we know that there's foreign organizations that are involved, and we know that they are manufacturing fake product, how to identify the difference between real and fake.
Absolutely. And one of the key things is, we're not, from our perspective, telling the pharma companies, you need to change your production line and insert this new machine, or you need to add some sort of DNA marker in your medicine, or put some new engraving on the pill. Nothing. Literally install a camera at the end of their production line and take pictures of everything coming down. That's it. It's as simple an integration of that because all we need are the pictures. That's the beauty of our technology. We have, as of a few weeks ago, our 51st patent on what we do. And so this thing is robust. It works. It's been deployed both in Europe and here in the US. And I'm super excited about what it can do in the world of pharma.
All right. So pharmacists, shout out to you, pharmaceutical manufacturers who are part of our network. I want you to take a look. Alitheon, that's ALITHEON. That's ALITHEON.com. Roy, I want you to come back. I want to form a panel discussion we have connections to the NABP. We have discussions to DCSA. Is it DSCSA? DSCSA, which is an organization trying to really govern online pharmacy proliferation and how that's actually expanding. I want to have you back, but I just want to thank you so much for taking time to talk with our pharmacists, our pharmacy professionals out there, but we have to have Alitheon back for sure.
Thank you very much. I really appreciate it. And I love what you guys are doing.
Thank you so much. We'll talk to you soon. Hey, what a great show. Thank you so much to Alitheon team. Thank you so much to Greg and Nikki for telling us the truth about what's happening in the state of Georgia and the impact on community pharmacy. We have to work together, RX, hashtag together, RX. in order to really make things change. That is your episode of This Week in Pharmacy. Can't wait to talk with you next week. Thank you so much.